Why do we need to talk 12 leads? What was the importance of them way back when? Well, MIs are the leading cause of death for both men and women. The earlier we can recognize the fact that they're having an MI, the faster we can treat it. The faster we can treat it, the greater muscle we save. Time is muscle, you've all heard that. Time is muscle. Well, there's two different kinds of therapy. There's reperfusion therapy that's going to happen in the cath lab immediately, and then there's the other therapy that'll involve more of a medication balance, and then they'll go to an ICU and be diagnostically sent for a cath at some later point. We are really concentrated on the ones that are the STEMIs. STEMI stands for ST Elevation MI. So the STEMIs are the ones you guys can recognize. And when you recognize them pre-hospital, you can notify the ER that you have a STEMI. And when you notify the ER activates the cath lab team. And when they activate the cath lab team, if it's in-house during hours, they're waiting on the ambulance to get there. Many times. I mean, 6 months ago we said, oh, there was this one time they were waiting. They're usually waiting on the ambulances if they've been given enough lead time. Cardiologists have been at the ambulance bay doors now waiting on EMS to get there. There's been several instances where the cardiologist doesn't even speak to the ER physician. He speaks to nobody but the medic. This is all kudos to the EMS. It's not kudos to the ER for activating it over house, although it takes them to do that. It's showing you that the cardiologists are trusting you guys on what you are calling. They trust your knowledge, they trust the fact that you've been educated, and your outcomes have been over the top, to be quite honest. It's been nothing but good right now. So they're doing this, and when they do this, when they activate so quickly, it reduces the time to perfusion. And when we reduce time to perfusion, we save cardiac muscle. So it's all about quality patient care and all about improvement of patient outcomes. So we want the patient not just to get out of the hospital, we want them to get out of the hospital and we want them to resume their normal daily activities, right? We joke all the time about we want them to become a taxpayer again. We want them to get their job back, go do what they're doing, and help us pay our god-awful taxes. So why is that happening so well? Because of you guys. Okay, so this is all a push to validate your knowledge that you already have. Door-to recognition, pharmacological intervention, and definitive care can be reduced. Okay, that's been proven. Those numbers that you see up there are not Anderson Hospital numbers. Actually, our numbers are a little bit better, to be quite honest. In 2009, those numbers were United States number. That was research across the United States for pre-hospital 12 leads. In 2009, the average reduction of time to reperfusion with pre-hospital EKGs was 25 minutes. And average reduction of cath lab activation with a STEMI alert from pre-hospital was 15.4 minutes. What you have to realize is your 12 lead in the field comes way earlier than what an ER can get a 12 lead. We love our ERs. Our ERs are capable and competent nurses and doctors. But the reality of it is this. If a patient walks in, they go to triage, then they go back and go to a room, and then from the room they get put in a gown, and then they get hooked up to the monitors, and then they get their vital signs taken, and then they get their history taken, and then a 12 lead either gets done or the doctor goes in and sees them and orders a 12 lead. So that time frame right there, from the time they walked in to the time the 12 lead happened, is usually supposed to be maybe under 10 minutes, but sometimes it's over. And if you look at the United States and the research done, it's well over that. You guys are doing that pre-hospital when they call you. You've got it in your hands. It takes away all of that time. Okay? Without it, they have to go through that process in the ER. Most important reason above all else is the time is muscle for the patient. It does have benefits and it does have limitations. We don't get something for nothing, right? Nothing's ever free in the society that we live in. So benefits are rapid identification in the early stages. Why that's important is because sometimes, although it's rare, sometimes someone's 12 lead will change when you begin reperfusion therapy. And you go, we don't reperfuse. Yes, you do. You give aspirin, you give nitro, that's the beginning of reperfusion therapy. Occasionally, rare, but occasionally, you will decrease their STEMI. And what I mean by that is the identification of the ST elevation on the 12 lead will go down. We had that happen here. I read the letter to you at Run Review last December. For those of you that weren't there, you don't remember, I'll refresh your memories. EMS called a STEMI on the radio. Okay, they said, we got a STEMI, did 12 lead, we got a STEMI. They come in, cath lab team was called, Dr. Geldmacher went into the room. back then, believe it or not, even though EMS called it, back then, what happened? ER ran their own 12 lead, didn't they? So ER ran their own 12 lead, and she says, that's not a STEMI, everybody stand down. Everybody take a break, relax, it's not a STEMI. And she says to the medic, why did you call it, tell me why you called it a STEMI. And he said, well, here you go, here's our 12 lead. And she looked at it and she went, oh my goodness, that is a STEMI. So she reactivated the cath team, they took him to the cath lab, and he had 100% occlusion. She said, she wrote a letter to you guys that I read, and she said, never would I have activated the cath lab team had it not been for EMS's 12 lead. That particular patient began to reperfuse, the ST segment began to drop and was almost normal by the time they got him here to the hospital. Doesn't usually happen like that, but hey, one person that we could recognize and get to the cath lab and save his muscle, that's all it means to us, right? One good save in there and we're happy little campers. So that's one reason, early recognition when sometimes it won't be possible in the ER. Another benefit is that it's just one piece of the puzzle. So when you combine it with the history and the physical exam, you can actually have a more definitive care plan, okay? If you only use the 12 lead, you're going to miss something. So if you look under limitations, one of the limitations is just that. It's just one piece of the puzzle. So I need to know physical exam findings, I need to know history, and then I need to see the 12 lead. I have to get everything grouped together in order to be accurate in what I am seeing on the 12 lead. I'm going to show you a lot of things today that are STEMICs. A STEMIC is something that mimics a STEMI, but if you were to just look at the 12 lead that I'm going to show you, you'd go, oh my gosh, that's a STEMI. But if I give you the history and physical exam findings, and then we look at the 12 lead and the components of it in the order we're going to talk about today, you'll very clearly see that that's not a STEMI at all. In fact, it's a STEMIC. Mimics a STEMI. What are some things that can mimic a STEMI? Pericarditis is one of them, that's a big one. Left bundle branches are another. When you have a left bundle branch, you cannot isolate out STEMI out of that because left bundle branches can distort the ST segments, and they can also mimic or even hide a true STEMI. So left bundle branches really hurt you in regards to being able to call a STEMI, which is one reason why we need to be able to decipher left versus right bundle branches. The other limitation of a 12 lead is this: it cannot rule out an MI. You guys all know there's such thing as STEMIs, there's also such thing as non-STEMIs. The difference? Treatment plans. They're both heart attacks, they're both bad, they're both cardiac muscle dying. STEMI goes to the cath lab, non-STEMI gets meds, and non-STEMI gets sent to critical care, and then they get diagnostic caths later down the road somewhere, hours, days later. Okay? It's a difference. So, benefits and limitations, like everything in life that we have. In 2009, in February of 2009, this was one of the first ones I received a picture on from the cath lab. I spoke with Bill Rogers when we started getting this ball rolling and said, hey, you know, we really need to see the post pictures of the reperfusion. And he said, no problem. So for many of you, you already know that if you bring in a STEMI and they were reperfused and everything was successful, I send you this picture by email. And it shows you what you did. This person here was brought in by EMS. This was their occlusion right here, full occlusion, you can see. Reperfused, there it is right there, reperfused. So those are the pictures that we share with you, share with EMS. The other thing that we share on those reports is the time to reperfusion, how long they were in the ER before they went to the cath lab, and then the actual time to reperfusion. Time to reperfusion doesn't mean when they went to the cath lab. Time to reperfusion means when that vessel was actually opened and blood flow was restored. So, not too long ago, we had a patient go straight from the ambulance bay door. Yeah. Straight from the ambulance bay, ambulance ER stretcher, cardiologist waiting, straight to the cath lab, from the ambulance stretcher to the cath lab table. So we would have thought we would have had a really short reperfusion time. Well, we didn't. We had a reperfusion time of like 34 minutes, which, don't get me wrong, that's super short, right? Criteria says under 90 minutes, so it's way short. But the guys were a little disappointed. They thought they were going to set a record. I said, what you have to understand is dependent upon the location of that infarct and dependent upon, how the cardiologist has to manipulate through and thread can all depend upon how quickly they get reperfused. 33 minutes, are you kidding me? That's phenomenal. That's unheard of. So, I guess they wanted it to be like 10 minutes or something. So those are great times, all because of EMS. Why or when does American Heart Association recommend that you do a 12 lead? Well, to be quite honest, Bob Page, we'll quote Bob Page. Bob Page has a famous quote that says, if you have a pulse and a problem, you should be doing a 12 lead. And American Heart Association pretty much agrees with him. If you look at everything they post about why to do a 12 lead, it's pretty much if you have a pulse and a problem. Okay? So we've got chest pain, dyspnea, nausea, vomiting, heart palpitations, diaphoresis, syncopal episodes. They have that feeling of impending doom. They're weak. They just don't feel good. Then you have the whole classification of patients with your silent MIs or your atypical presentations. You have your diabetics. You have your women. We're a whole category of our own. I know you realize that, but beast of our own, right, when it comes to clinical presentation of chest pain. Careful. And then you also have your people that have had heart transplants, so they will present differently. So you have this whole category. Geriatrics in their own will present differently. A lot of geriatric patients are simply weak. A lot of geriatric patients are simply short of breath. Those all are possibilities for MIs. So we do 12 leads on all of them. So something to keep in mind, why or when we do them. It's 12 leads, it's 12 views of the heart, but it's truly only 10 electrodes, right? So that kind of seems like common sense at this point. I'll remind you all that in 2005, that was one of the biggest questions everybody had. Where's the other 2 electrodes? So you've come a long, long way in 6 years. Your leads. Leads 1, 2, and 3 are limb leads. You deal with those, you've been dealing with those since your days of paramedic class. Limb leads 1, 2, and 3. You're used to looking at all of your cardiac rhythms in lead 2. Okay, another very popular Bob Page saying. In lead 2, what? You have no clue. That's right. Lead 2 is okay for a monitoring lead. It is not okay as a diagnostic lead. You cannot diagnose in lead 2. Lead 2 is very, very, very poor view of the QRS, and that's your ventricular depolarization. Okay? So you really want to make sure you're getting these 12 leads and not relying upon an old thing that you're used to from way back in medic class. So leads 1, 2, and 3, limb leads. Okay? On your limb leads, you know you're reading bipolar limb leads and you have a negative and a positive pole. Your AVR, AVL, and AVF are augmented voltage leads. Those read to a central terminal point in the heart. So AVR reads from the right to the central terminal point, AVL reads from the left to the central terminal point, and AVF reads from the foot area to the central terminal point. See, they made those easy, right? AVR, AVL, AVF. V1 through V6 are your precordial leads. Your precordial leads are what reads on a horizontal plane. So it's a horizontal plane or a look into the heart. Please also know that all of these views, they are not reading the right ventricle. You do not get a view of the right ventricle on a 12 lead. The only view you're going to get of a right ventricle or the posterior side of the heart is from a 15 lead. Okay? So 12 lead mostly looks at your left ventricle. Why mostly at the left ventricle? Where do you think the majority of all MIs occur? Left ventricle. Why the left ventricle? What do you think? Only, you got to sign it down. So I don't have. It's the big one. That's right, it's the big one. It's the workhorse, isn't it? Most easily occluded, it's the workhorse of the heart. Okay, so limb leads, augmented voltage leads, and precordial leads, V1 through V6. Those are all of your leads. A 12 lead is a 10-second view, is what it is, a 10-second view. You get 2.5 seconds in each lead grouping. So when you're looking at actually on this handout, open it up to the second page. This page right here that has the red ink on it. When you're looking at that, leads 1, 2, and 3 going down from the top. 1, 2, and 3. Y'all see that? That is a 2.5 second view of lead 1, 2, and 3. When you move across, you see AVR, AVL, and AVF. 2.5 second view. You move across, you have V1 through V3 going down. 2.5 second view. And then V4, V5, V6 going down. 2.5 second view. So collectively, you've got yourself a 10-second view. Okay? All right. Moving on. Lead 2, as we said, was a single lead dependent. It only gives you one look at the heart. Looks for the bottom of the heart looking towards the right arm. Good for determining an electrical rate. However, it's not very good at determining a pulse because you should be taking that manually. It's a decent view of the P waves, but it's a horrible view of your QRS complex. How do we get a 12 lead? How do we acquire it? Well, this picture is much better on your handout. It's also on the same handout you were just looking at. Flip one more page, and there it is. Okay. Mark, will you come here and stand up here a minute? I don't want you to take your shirt off. All right. So lead placement is imperative in order to get a good tracing and a good reading. You can throw off your access. You can throw off your access if you don't have your leads on properly. So you want to make sure that leads are on properly. So with the leads, talking about them, let's first talk about your limb leads. Where do your limb leads go? On the limbs. There's your clue, right? On the limbs. Why make such a big deal about it? Because forever EMS has been putting, white on right and smoke over fire. You're white, you're black, and you're red. Forever, right here on the chest. That's not where limb leads were intended, right? When Dr. Einthoven put his fingers, his hands, and his foot in buckets of salt water in 1904, he didn't have the salt water on his chest. He had them in his limbs for the proper tracing. Why has EMS forever gotten away with placing them here?
Was it 1904? Convenience.
Nope, that's not the right answer.
Reduce the artifact.
Reduce the artifact. It does reduce the artifact. That is correct. It reduces the artifact from patient moving around, you getting a blood pressure, starting an IV, doing whatever you were doing. It does reduce the artifact. The problem is it's not as accurate as if you had them on the limbs. Remember, lead 2 is not very good anyway, and now here we're going screwing with where we're putting it. Lead 2 is meant to be on the limbs. When you're doing a 12 lead, it is not optional. You cannot put the limb leads on the chest. The limb leads have to go on the limbs when you're doing a 12 lead. Okay? So when you're doing the 12 lead, we have a RA, an RL, an LA, and an LL, right? Left and right, arm and leg. Kind of tells you that. So where would I put them on the arm? So the left arm, patient's left arm, where am I going to put it? Anywhere underneath the shoulder girdle right here and above the wrist. Somewhere in here. It doesn't matter. Just don't put it over a bone. Don't put it over the wrist, don't put it over the elbow, don't put it up here on the shoulder. Put it here, put it here, put it here. Anywhere on the limb, above the wrist, below the shoulder. Okay? How about the leg? The lower ones, where do they go? Woo! That's all right. Here, come stand here where they can see you. Where's his lower limb leads going? Anywhere below what? What's the area that's going below? Yeah, it's actually the inguinal artery. If you just want to say the femoral artery, that's fine. It has to go below the groin area. And where does it have to be? Above the ankle. There you go. So you can put him on his thigh, or you can put him down here. It doesn't matter. Try to keep it off of the actual tibia, though. You don't want it right on top of the tibia. Put it off a little bit laterally or medially, just to get it more on muscle instead of bone, okay? So that's my limb leads. Get out of the light just a little bit. Go to the light. All right, that's my limb leads. Now I want to put my precordial leads on, V1 through V6.
Do they have to be pretty well the same place on the limbs, on both limbs, or like one up high on the arm and then the other
Try
side?
to keep them even. Try to keep them even.
Okay.
Okay. Precordial leads, V1 through V6. First of all, I have to prep my patient. I can see this little chest hair sticking out right here. What if he's got a sweater vest on underneath that shirt?
Manscaped.
Yeah, we need to do some manscaping, right? So put on electrode, rip it off, rip hair. No, not really. Well, maybe. We can't, if it's on top of hair, we have a real good chance that it's not going to stick very well. Okay, and it's not going to conduct very well. So if you did that and you thought you got it down nice and firm and all of a sudden your machine's not acquiring, or it acquires and the tracing is crap, that's because you don't have good conduct with your electrode. So wipe off any sweaty areas, debride them if you need to. Some of you guys have the electrodes that have the ridges on the back of the white sticky stuff. Turn that around. That's not braille back there. It's actually used to rub the skin. You can get off dead skin cells. Sorry. You can get off dead skin cells of geriatric patients. You can get a lot of lotion off in those areas from, women, geriatric women put a lot of lotion on, baby oil, whatever the case is. You can get that stuff off with some aggressive wiping. There are even recommendations, believe it or not, there's recommendations for the very finest sandpaper you can find. You can actually use that in order to get the electrodes to conduct a little better, in order to get the dead skin cells, the oils, and the lotions off. So get your patient properly prepared. V1 through V6. First we're going to start with V1. Proper landmark of V1, because we have to hit our landmarks. V1 goes where? Yeah, V1 is on my patient's right side, and I'm in the fourth intercostal space, right? So I want to find his fourth intercostal space.
It's gonna get harder if you go down.
Even on board I can feel it, okay? So this is his sternum. He's so muscular. What are you thinking? So this is his sternum right here. Where do I want to be from his sternum? Yeah, I want to be to the right of it, maybe about an inch or so, okay? So fourth intercostal space off of the sternum. Now I want to put V2. Where does V2 go? Fourth intercostal space on the left side. So I have V1, V2, okay? Now comes V4. V4 comes next. V4 is mid-clavicular, fifth intercostal space. So mid-clavicular, and I want to go fifth intercostal space. All right? So I'm about right up in here. So fifth intercostal space for V4. Where does V3 go? In between 2 and 4, right? How about V5? Here's V4. V5 goes about right here, and then V6, the anterior line of the axillary portion. So the front of his arm, anterior, that's V6. Okay? So I have 1, 2, 3, 4, 5, 6. Around his heart. Those are horizontal views. They're looking into the heart. Okay? Very important that I get proper positioning. If your patient's capable of lying supine, have them lie supine. If they won't, you want to do a 30-degree tilt of the head or the bed, go for it. If they absolutely are refusing to even do that because maybe they've got CHF, you do the best you can with what you've got. We got patients that will not lay back for us, then let them sit up. Okay? You work in an environment that doesn't always allow the normal. So work with what you've got. All right? What about a patient who's shaken really bad? Maybe he's got Parkinson's and he's shaken. Is my machine going to acquire? The machine's not going to acquire, right? So I need to try and stop you shaking. Did you know you can hold their hands and it's not going to interfere with the tracing of the 12 lead? You can do that. Okay? It won't interfere and it might reduce it might reduce the actual time it takes the 12 lead to acquire, and then it also might reduce the actual artifact that you might see on there. Another thing is, have you ever noticed on your 12 leads how sometimes they go up, the tracings, and they go down? How's your patient breathing? I bet those are respirations that are out of control. If you can have your patient hold their breath, your tracing is clearer, and it takes less time for the machine to acquire. Sometimes it's not going to be reasonable for them to do that, but it's worth a try. Okay? Hey, buddy. How about holding your breath for me for just a few seconds? Some of your new 12 leads, you guys have some machines out there that are acquiring in about 1 or 2 seconds, and it's blowing me away how quick they are. Some of you got the old 12 leads and it's taken 10 seconds to acquire, which is not that long, but when you see the new ones and the speed of what the new ones are doing, it's unbelievable. Because now my patient that's struggling might only hold their breath for 1 or 2 seconds instead of attempting to for 10. Or it might take us 1 time to acquire instead of having to try 3 times. So those new machines are phenomenal that you guys have. All right, thank you, board. All right, your picture, this picture here that you have was the one in 08. I gave you the one in 08. The one that you received in 03 looks like that. That's history for you. That's 2003's picture that was given to you, and then of course the 08 is the one you have in your handout, which is the most recent. All right, a few things about what you're looking at. When your 12 lead comes out, look at that picture that had the red writing on it for me. Over on the far left-hand side, you're going to see this right here. Y'all see that? Okay. This right here is a measurement of the amplitude to know if your machine is calibrated correctly. Your amplitude should be set so that that large rectangular box is 10 small boxes. If it is, then your amplitude is correct. Okay? You should be checking that periodically, like maybe when you do rate checks in the morning, because you can imagine if that's dialed way down, if somebody got in there and messed with your settings and that's dialed way down, what does that do to your ability to be able to identify ST elevation? It diminishes it, right? Because you're not going to recognize it. So make sure the first one of the day, or run a practice one or something, make sure that you've got 2 small boxes on your 12 lead, okay? Then the rest of the measurement for time is the same as what you guys have been doing forever. Every small box is 0.04, and 5 small boxes make a large box, which gives you the 0.20, right? So you've been doing that forever. Time measurement remains the same across the strip, okay? The format that we're going to use for identifying STEMIs, as it says in bundle branches, is called the 5+3. Now, in 2009, I shared with you the fact that, hey, we didn't have 12 leads on the trucks when I was running. That was unheard of. You know, I wonder now how many people we might have facilitated their death in by not knowing they were having right ventricular involvement and feeding them nitro all the time. You have to wonder about some of the things that we didn't know any better about all those years ago. So when I started having to teach this, I had to start doing a lot of research and going to a lot of classes to be able to hand this information off. The best format I found as far as simplicity went was 5+3. It was simplified, but no compromising accuracy. So that's the one we chose to use back then. Still believe, even continuing to research, that this is the easiest format for EMS. With that said, the 5+ is what you've been doing for years. The 5 means, what is my rate? What's my rhythm? Is it regular or irregular? Do I have P waves? Are they round? Are they upright? Do I have a QRS for every P wave and a P wave for every QRS? Remember those days? What's my PRI measurement? It should be somewhere between 0.12 and 0.20 if it's normal. And then, of course, my QRS complex, what does it measure? A QRS complex should be less than 0.12. It should not be 0.12. It should be less than 0.12. When a QRS complex, and we're talking about adults because it is different on kids. With adults, if it hits 0.12, that is considered wide. So it should be less than 0.12 on your QRS complex. So that's the 5. That's the 5 you've been used to forever. To that, we're going to add 3 things. We're going to look for axis deviation, which indicates a block. We're also going to look for bundle branches when applicable. And we're also then going to do the ICO leads format, which means I'm going to look at inferior, septal, anterior, and lateral leads. So what that last one means, for those of you that might need a visual on this, adults are visual creatures. Look at this one right here. ICO leads is looking at lead groups. So if I'm looking at the inferior lead groups, I am looking at the ones that are kind of that pea green color or gray color. So it says lead 2, 3, and AVF. And that's the inferior view of the heart. Does everybody see that? Okay. If I'm looking at septal, I'm looking at V1 and V2. That's the light pink color. V1 and V2 is septal. If I'm looking at anterior, it's the royal blue color, and it's V3 and V4. And then if I'm looking at the lateral leads, it's the turquoise one. It's lead 1, AVL, V5, and V6. That's the lateral views of the heart. Why it's important that you know the lead groups is because in order for any finding to be significant, it has to be a finding that is in 2 or more of the leads in that group. So when you're looking at inferior, that finding is only significant if it's in 2 or 3 of those 3 lead groups. So when you look at inferior, you have leads 2, 3, and AVF. For that finding to be significant, it has to be in at least 2 of those lead groups, meaning either 2 and 3, 2 and AVF, 3 and AVF, or sometimes all 3 of them. Okay? When you're looking at septal, V1 and V2, in order for it to be significant, it has to be in both of them, because there's only 2 groups to that. When you're looking at anterior, it has to be in both of them. And when you're looking at lateral, you've got 4 boxes in lateral, right? You need it to be in 2 of the 4 in order to be significant. That's what you're looking for. Okay, any questions on that part? Okay, then we're going to dive right into the axis. Moving right along. Okay, so what is axis? How do you even define it? Well, axis is the general direction of the electrical impulse as it travels through your heart. So normally the electrical impulse travels from top to bottom, right? You'd all agree. Top to bottom, top to bottom, top to bottom. From the SA node to the Purkinje fibers. Where's that SA node? Real high up on that right atrium, right? Top to bottom, firing away. So if I deviate from that, that's what axis deviation it means. For some reason, I'm not flowing from top to bottom. For some reason, I might be flowing, I hit a block in the road, and I deviate. I go a different direction. That's axis deviation. The electrical impulse deviates from its normal flow. Sometimes it's an okay finding, which you're going to learn how to determine here in about 30 seconds. Sometimes it's normal, sometimes it means a block. You can figure that out on the 12 lead very quickly. There is such a thing as physiological left, which is normal. There is normal. There's pathological left, which means it's an anterior hemiblock, and there's a right axis deviation, which means it's a posterior hemiblock. So the definition of a hemiblock is a block of one of the 2 fascicles of the left bundle branch system. You all know that the bundle of His, the electrical conduction system goes from the bundle of His to the bundle branches. The left side has 2 fascicles, the right side has 1. Right now, for axis, we're talking about one of the 2 left ones is blocked. Okay? That's what an axis hemiblock is. Oops. Go back. Okay. Clinical significance of a hemiblock. 4 times higher mortality rates for patients that are having an MI. Because this is a block they have along with the MI. Okay, so 4 times higher mortality rate. Also, a really good chance that they're going to go into some major kind of 2nd degree, type 2, or 3rd degree block. So for you as an EMS provider, you've got someone that has a pathological left or a right axis deviation. Where's your pacing pads at? Where are they at? You got them ready to go? Got them ready to slap on the chest? Because AHA still says second degree, type 2, and a third degree, we should be pacing if they're symptomatic. Well, I'm saying they're probably symptomatic or they wouldn't have called you. Okay, so are you ready to treat them if you need to? Because there's a good chance they're going to progress into that. And there you go, risk factor for that, as well as some instability with ability to maintain their cardiac output or their blood pressure. All right, so how do we determine access? I want you to look at this single piece of paper that you have here. Now, this single piece of paper has been around a long time. I didn't make it up. I copied it out of Bob Page's book. Why did I copy it? Because when you take one of his classes, he says, copy this piece of paper and carry it with you. Why not, right? Why not cheat the Grim Reaper is how he says it. So use this. A lot of services have this laminated and taped up in the back of their ambulance rigs. Okay, that's perfect. Do that. Tape it to your monitor. Keep it in your shirt pocket. Whatever works for you, right? It's all about what works for you. What you're going to be looking at, if you look at the cheat sheet, on the far left-hand side is a numerical value. If you are a number person, if that's the side of your brain that works best, then you want to look at the number on the 12 lead. And what I mean by that is this. On the 12 lead, you will see all these numbers up here at the top. Those numbers are really, really accurate as long as your machine's calibrated. They're very, very accurate numbers. Now you all know that the interpretation that prints out across the top of a 12 lead is only about 50% accurate. So you can't use that, but you can use these numbers. So if you're a number person and you want to compare the number on that sheet to the number on the 12 lead, you can do that. So when you're looking at these numbers, real quick since we're there, let's look at them. It tells you that the ventricular rate is 95. Now I'm going to challenge you, that is an electrical ventricular rate, that is not a pulse rate. You have got to take a manual pulse. Okay? The next thing is the PR interval. It measured it out at 148, which means 0.14. Is that within normal range? Is it? Yeah. It's supposed to be between 0.12 and 0.20. That's perfect. So why try to count those little itty bitty small boxes when you have really bad vision, right? Just look at your numerical values. The next number down is QRS duration. It says it's 108. That means 0.10. Is that okay?
Yes.
Absolutely. It's fine as well. And then the very, if you know how to look for, if you know why it matters on a QTC interval, you can look at that. For all beginners, everybody else that's not advanced in 12 leads, you will ignore that at this time, okay? If you go to the next one, it says PRT access. You want the middle number, the R access, and that number is a 124. That's the number you'd be looking at if you're a numbers person. Now, I kind of challenge you to the fact that it's a little easier to do it the other way. So the other way is what we're going to review. Look at your paper and look next to the numbers where you see it says lead 1, lead 2, and lead 3. Those arrows, they're really not arrows. They're a direction of a QRS measurement is what they are. Okay? So if you look at that sheet and the QRS in lead 1 and the QRS in lead 3 is up, that is a normal access deviation. They do not have a block. And you can see that as you progress all the way to the right side of that. Lead 2 only needs to be looked at one time. Other than that, we can just look at lead 1 and lead 3. Okay? Go down to the next box. QRS in lead 1 is up. The QRS in lead 3 is down. So my QRS complexes, or my thumbs, if you like the thumb game, lead 1 is up, lead 3 is down. They're looking away from each other. My QRS complexes are looking away. So LA is a left axis deviation. I am forced to look at lead 2. If lead 2 is 50-50 with the QRS complex, or it is up, then both QRS complexes are up, and that is considered a physiological left, and that is a normal finding for an adult patient. So you do not have a block. Do you all see that going across there? Are you all traveling across? Okay, go down to the next one. QRS complex in lead 1 is up. QRS complex in lead 3 is down. You all see that? Look at lead 2, because I have an LA looking away from each other. I look at lead 2, and lead 2 is down. That is a pathological left axis deviation, and that is one of the 2 hemiblocks. That is an anterior hemiblock. So up, down, down. Pathological left, patient has an anterior hemiblock. Do you all see that? Everybody's good? You see it? Okay. Next one. Lead 1 is down. Lead 3 is up. My QRS complexes are looking right at each other. That's a right axis deviation. And that is a posterior hemiblock. Okay, both of them are blocks. Both of them mean my patient has a progression to go into a bigger block. Also means if my patient's having a cardiac event, they have a 4 times greater chance of dying. You have to recognize it as a block. Okay, go to the next one. Lead 1 is down, lead 3 is down, lead 2 is down. See all those down, down, downs? Down, down, down. It's called extreme right axis deviation, and the majority of the time you love it as VTAC. Is how you love it. Okay? So you all know with that one that your patient might be compensating right now, but watch out, because they're not going to compensate very well if you don't fix them. Okay, that's access. So look up here. Look at lead 1. Which way is my QRS complex in lead 1?
Up.
It's up. Which way is it in lead 3?
Down.
Down. So my QRSs are looking away from each other. What do I have to look at now?
Lead 2.
Lead 2. Lead 2, the greater majority of the QRS is down. So it's up, down, down. What do I have? I have a pathological left axis deviation, which is known as a posterior hemiblock. Nobody's asking you to memorize that cheat sheet. Forever we've given you that cheat sheet because Paige gave it to us and we said use it. Use the cheat sheet. Okay?
Yeah. Posterior?
Oh, it's anterior. Come down, this is anterior. Left axis deviation, anterior. Okay? Do you all see that on the practice one? Trust me, we've got 20 things we're practicing today after we get all this information in. Okay? All right, let's move on then if you see that. If you see that, we're moving on to bundle branches. For those of you that have been around a long time, I can tell you that when I went to class, we were taught, well, if your QRS complex in lead 2 has a bigger rabbit ear on the left, it's a left bundle branch, and if the bigger rabbit ear is on the right, it's a right bundle branch. Absolutely false. There's no criteria and no studies that establishes that as a rule. So, you know, again, I wonder how many times we did wrong. A bundle branch block is a block of either the right or the left bundle branch. So at the bundle it is, we go to the left side with 2 fascicles and to the right side with 1. So we're looking at a block somewhere on the left side or on the right side. Okay? The ventricles are supposed to fire in sync with each other, right? You all know that. They're supposed to depolarize or contract at the exact same time. Because if I depolarize at the exact same time, left and right ventricle, I'm doing pretty good at maintaining my blood pressure, my cardiac output, right? Because the left ventricle sends in blood to the aorta, which goes to all the arteries in the body, and the right ventricle sends in blood to the lungs, which is going to get, through diffusion, get oxygenated and sent back to the left side. So I maintain my cardiac output pretty darn good when this happens. Okay, that's called synctium. They're in sync with each other. Okay, synctium. Come here, Welch. Come on up here. 4 paramedic classes in today's class. Come all the way around. McKay, you can come up here with him. Okay? They've already practiced this a long time ago, so they know what they're going to do, I think. Go ahead, hold hands. No, hold hands. Remember, these are your atriums. Atriums. And then your ventricle. So go ahead and do it together. Oh dear. Keep going.
They're all white.
There you go. Now you got it. Now you got it. So patient's blood pressure is pretty dang good. Cardiac output, keep going. Cardiac output's being maintained, and they're doing it somewhere between 60 and 100 times a minute, right? There you go. You're about 60. Good job. Okay, stop. What happens No. What happens when, because they're still doing this, what happens when the left ventricle gets a block? How does the left ventricle get depolarized? Does anybody know? Because there's a block. Block over here. Impulse doesn't get through down to the left ventricle. He's not squatting. Okay? What has to happen is he goes ahead, both atriums depolarize, both atriums, McKay, atriums, that's your arm. Okay? Both atriums depolarize. Okay? Ventricle depolarized. Okay, try one more time. Atriums depolarized. Ventricle depolarizes, comes back up, now you depolarize. There you go. Why is that?
Retrograde.
Yeah, he has to be depolarized in a backwards fashion or retrograde because his impulse spreads through the right side first, then goes over to the left side, and then you get to depolarize. You want to try it one more time? Create a visual they're going to remember. Okay, concentrate. Here we go. All right, go. Atriums, ventricle. Yay! Okay, sit down before you mess it up again. Okay, so they're out of sync, aren't they? They're doing this number, is what they're doing. What happened to my cardiac output? It's going to go down. How significant it goes down, believe it or not, depends upon the size of the block. You guys get to know that by looking at the width of the QRS complex. The greater the width of the QRS complex, the greater your patient's chance of decreased cardiac output. Ejection fraction decreases below 50% when a QRS complex reaches 0.17. Think about that. Decreases by 50% at 0.17. So you're looking at your patient, they look okay, they're talking okay, they seem to be doing okay, and holy crap, the QRS just measured 0.18. Well, don't panic. Just know that the next blood pressure might be decreased a little bit. They might start decompensating on you because their ejection fraction's going down. Why does it matter? Because obviously it's patient care, number one. Second of all, we know that bundle branches can be associated with MIs. Okay? The other thing we have to remember is, what if that patient had that anterior hemiblock we just found, and now they have a bundle branch? How many blocks is that? 2 blocks for my patient. What are their chances of progressing? Decompensating. Significant. Again, it's about patient care. Get ready, because they're going to decompensate on you. Quick ETA, maybe not on you, but you better tell the hospital what your findings were. Okay, the right bundle branch single, left anterior and posterior hemifascicles, higher mortality on the left. We all know the left side feeds the body, so you would expect a statement like that. Ventricles get out of sync with the bundle branch, supposed to be depolarized in less than 0.12, greater than 0.12, or 0.12 and greater equals reduced preload, okay? Greater than 0.17, ejection fraction by 50% reduced. So that's significant for your patient. Bundle branches can hide or mimic STEMIs as well. That is left-sided bundle branches. Left-sided bundle branches can hide or mimic STEMIs. Right side, you'll be all right. Okay. Questions? All right, here's how you're going to decide if they have a left or a right going on. Here's your criteria. First of all, the QRS has to be 0.12 or wider, or you don't care, okay? So when you look at your width of your QRS, if it's less than 0.12, there is no such thing as a bundle branch on that patient. You only care if it's 0.12 or greater. So criteria, first of all, QRS must be 0.12 or greater. Second of all, you're going to look at V1. You cannot determine a left or right bundle branch off a lead 2 strip or anything else. It has to be V1. For those in here that are advanced in this, you do have V6 criteria. And if you are comfortable with V6, if V1 is not conclusive for you and you are comfortable with V6 criteria because of your advanced training, you go for V6 criteria. For those rest of us in here that are at beginner's levels, V1 is it for you. It's the end-all, be-all for you. Beyond that, you're not there yet. Okay? What's that?
Gotcha. B1. Sticking with B1.
V1 for you. Okay?
Thank you.
You're welcome. All right, so we use what's called turn signal criteria. I don't know if you know the history on turn signal criteria. It's been around for a long time, but it wasn't allowed in curriculums until about maybe 07-ish, 08-ish. It's been in curriculums. Turn signal criteria is a simplistic way of determining left or right, and once you understand it, it seems too easy to be true, but it really is that easy. Bob Page will tell you the story of how this got to be published and accepted the way that it is, and the story that he tells is something like this. His paramedic class was interpreting bundle branches based upon turn signal criteria, and the cardiologist at that hospital said it wasn't possible. They didn't like it, it was too easy, etc. So they went against each other. It was basically like they did 1,012 lead interpretations of bundle branches. The cardiologist group against the paramedic class. The paramedic class got all of them correct, and all the cardiologists did not. So the turn signal criteria was established based upon that, and the fact that it is, it has been proved and tested now. So you're allowed to use this. It's published in the books now, it's everywhere, so why not use it? It's pretty easy once you get it. In order to use turn signal criteria to determine if it's a right or a left bundle branch, you have to find a J point. So you have to know where a J point is, and I listed that on the PowerPoint for all of you that might have forgotten. The J point is where the QRS complex meets the ST segment. Okay, where the J point meets the ST segment. So that's what the circled dot is up here. So this is a J point circled here, and that's a J point circled up there. Okay, can you all see the circle? Okay, those are J points where the QRS complex meets the ST segment. Okay, so you find the J point and circle it. Now, in reality, once you get used to this, you're not going to be circling J points. You're going to be just visualizing it in your head, and that's what you're going to do today, and you'll see how rapid you're capable of doing that. So we find it, we circle it. Next step, so you can follow along after you leave here today, draw the line into the QRS complex until it's halfway through the terminal wave. Terminal means, of course, like the last wave. This is my last wave here, and that's my last wave up there. So draw a horizontal line halfway through the terminal wave, so it puts me right here. Then I go down or up depending upon which direction the complex goes. This one goes which way? Down. So down. Okay? It tells you if you need a visual to shade this area in and look at which direction the arrow points. If the arrow points down, it's a left. If the arrow points up, it's a right. Okay? The other way to do it is called turn signal. Turn signal criteria, some adult learners need actual different visuals. So if I'm driving a car and I put my blinker the direction of the arrow, so if I turn my blinker down, I'm turning my car which way? Left. Left bundle branch. If I put my blinker up, I'm turning my car which way? Right. That's a right bundle branch. That's it. Okay? Seem ridiculously easy? It does. Okay, once you get it, it seems really too good to be true. That's turn signal criteria, and it works. Okay? Find the J point, draw a line halfway into the terminal wave, and then draw it down or up depending upon which way the complex goes. If I go down, I'm turning my car left, a left bundle branch. If I go up, I'm turning my car right. That's a right bundle branch. Okay? Again, why are bundle branches significant? Because they can hide STEMIs, mimic STEMIs, decrease cardiac output, and the bottom line is it's a block. The other thing we have to realize about bundle branches is this. Some people don't have a bundle branch when they're sitting still like this or they're doing their daily activities. So you guys are all sitting in here. I don't know anybody that has a bundle branch in here, but I don't know all your history either. So there might be somebody in here that they're fine sitting here, but then they go outside, they run up and down the flight of stairs, they run a couple of miles, they do some physical activity. All of a sudden, they might be dizzy, they might be lightheaded, they might be short of breath. They might become symptomatic during exertion. Then they sit themselves back down, they rest again, and guess what? It all goes away. It's quite possible that they are a exercise-induced bundle branch, okay? That it only comes on with exercise. So new onset, exercise-induced, or what some people call rate-dependent. So they don't have it unless the rate of their heart rate reaches a certain number, and then it's a rate-dependent bundle branch. So once their heart rate reaches 120, they've got a bundle branch. Okay? Let's look at this one. Let's start at the beginning with access, since we've already learned access. QRS complex in lead 1 goes which way?
Up.
Up. QRS complex in lead 3 goes which way?
Down.
Down. So they're looking away. I need to look at lead 2. In lead 2, I am 50-50. Do I have a problem or not with access?
No.
No, not a problem at all. That's a physiological left. All is good because I am up, up, down. Y'all see that on your graph? Up, up, down? Okay. Now let's look for, that's right. Now let's look for QRS. I'll tell you that the width of the QRS on this printout is 0.16. Do you have to worry about a bundle branch?
Yes.
What lead would you like to go to?
V1.
V1. So you go to V1 over there. Okay? You're at V1 and you need to find the J point. And I don't have, I wish I had a pointer, but I don't. Do you all see where the J point is? I can pull the slide down and point to it if you want. Because I'm not standing on a chair. If I fall off, I know what will happen to me. So you find the J point. Visually in your brain, circle the J point. Draw a horizontal line over, and then draw it either up or down, terminating it into the complex. Drive your little car. Put your little blinker on. Are you turning your car left or are you turning your car right? You're turning your car left. That's a left bundle branch. Okay, what do we know about left bundle branches? Well, they can hide or mimic STEMIs. It could be a new onset. It could be decreased cardiac output depending upon the situation. 0.16, he's getting pretty far up there with ejection fraction going down. So really want to monitor my patient. That's a block going on. Here's the next one. Let's do access first. QRS complex is going which way? Down in 1. How about in 3? Up. So what are they doing?
Looking at.
Down and up. They're looking right at each other. Do I have an access problem?
Yes.
What do I have?
Right.
I have a posterior hemiblock, a right axis deviation of posterior hemiblock. Okay. So now let's look at our QRS. I'll tell you that your QRS measures 0.14. Is that too wide? Which leads should you look at? V1. Look at V1. Find your J point. Visually draw your line over and either up or down. Do you have a right or do you have a left bundle branch?
Right.
I have a right bundle branch and I have a posterior hemiblock. What does my patient have? 2 blocks going on. Okay? So your patient's got a couple of blocks going on. Chances are he's presenting as a cardiac event. Okay? All right, now let's go to, are you guys okay on bundle branches? At this point, we'll practice a lot more. You okay at this point? Okay, moving on then to the lead groups. I see all leads. That's the very colorful paper that you have. The big one that you can see easier. Okay? So the first set of leads we're going to look at is the inferior leads. 50% of the MIs take place in inferior or the right coronary artery. So right coronary artery, inferior leads will look at it, and about 50% of MIs there. You guys see a lot of inferior MIs. Okay, inferior MIs are bad, but please know that the most deadly for your patient is actually an anterior MI. Anteriors are very deadly for your patient, so all are bad. We have to remember that. Everything is bad. We don't want to be that patient, but anteriors tend to be the most deadly. I should say fatal, right? So location, inferior, 2, 3, and AVF are the leads I'm looking at. Make sure you know where they're at on that paper. In order for anything to be significant, it has to take place in at least 2 of those 3 sections of leads. Okay? 2, 3, and AVF. Septal, that's the left anterior descending. I will tell you that you're not being tested on the right coronary artery and the left anterior descending and those things, but it is expected that you know your groupings. It's expected that you know inferior, septal, anterior, and lateral, as well as your reciprocals that we're going to talk about here in a second. So septal is your left anterior descending. That's your V1 and your V2. Okay. Anterior, is also your left anterior descending, and it's V3 and V4. And then lateral is your circumflex artery, and that is lead 1, AVL, V5, and V6. Okay, and that's how they correlate to your paper that you're looking at. So on the right-hand side of that screen, you see something called reciprocal. Reciprocal means the opposite. So if I have ST elevation, ST segment elevation in 2, 3, and AVF, my reciprocal change, or my opposite, would happen in 1 and AVL. You see that on the up here, or your paper, wherever you're looking. So that means I would have depression in 1 and AVL. Now you don't always have to have a reciprocal, but I will tell you that when you have a reciprocal is a significant meaning to the fact that that is a STEMI happening. Okay? So I've got elevation in 2 and 3, and I've got reciprocal in 1 and AVL. That patient's having an inferior MI. All right? If you don't have a reciprocal, but they still are walking like a duck, quacking like a duck, smelling like a duck, and everything else that goes along with a duck, but you don't have a reciprocal, then you need to tell the ER, look, I've got elevation in 2, 3, and AVF. This is how my patient is presenting, but I do not have reciprocal changes. If you don't have reciprocal changes, it doesn't mean that's not STEMI. It's just that you don't have that official BAM stamp in your face. This is what that patient's having, okay? So you want to make sure that you communicate that to the ER. I do not have reciprocal, or I do have reciprocal. Make sure they understand that, one way or the other. If you look at septal, septal does not have a reciprocal. There is no such thing as a reciprocal change for septal leads, only the elevation. For anterior leads and lateral leads, the reciprocal for both of those groupings is 2, 3, and AVF. Now, do you have to have it in all three, 2, 3, and AVF? No, you have to have it in how many?
2 or more.
2 of the 3. You have to have it in 2 of the 3. So if I have depression in 2 and 3, or 2 in AVF, or 3 in AVF, that's reciprocal. Okay? The very last part of this slide that you see refers to, as I put over here, the 15 leads. Now I will tell you, the 15 leads are becoming popular because 15 leads detect posterior MIs as well as when the right ventricle is involved. A right ventricle is involved over 50% of the time with an inferior MI. Why do you care? Well, you care because the right ventricle does what for the heart? It provides all of the output to what? The lungs, and then to the left side of the heart. So when the right ventricle is involved, the right ventricle is trying to maintain preload. Trying to maintain preload to maintain blood pressure. So what does your body do when it's trying to maintain a blood pressure? What do your vessels do? They constrict. Bam. Let's clamp down. Okay? Now, okay, let's give them some nitro. What do you do when you give nitro? Dilate. What's your patient's blood pressure do? Tanks. Okay? You guys are eligible, of course, to give a nitro to anybody whose blood pressure is over 100 systolically without an IV line in place. However, I will challenge you to the fact that if you give a nitro and you tank their blood pressure, or you ran that 12 lead and that's an inferior, don't you dare give another nitro until you've got that IV line, which is protocol, first of all, but sometimes overlooked. You've got that IV line, and you've checked if they got right ventricular involvement or not. Because a lot of times with right ventricular involvement, you've got to give them as much fluid as you can just to even maintain their blood pressure. Okay? Right ventricle's involved. How are lung sounds going to be? Right ventricle is damaged, you vasodilated. How's lung sounds?
Clear.
Clear. Why?
Because
Because it's not even getting there. You decreased preload. It's not even getting to the right ventricle. If it doesn't get to the right ventricle, is it going to get to the lungs? No, your lung sounds are clear. What might you see on people with right ventricular involvement? Let's say you don't have time to do a 15 lead. You've got assessment qualities and capabilities that you can tell if the right ventricle is involved. Clear lung sounds, distended neck veins, that's right, distended neck veins as well, clear lung sounds, and the blood pressure dropped on you more than you would have expected with 1 nitro. Okay, you've got all the signs in front of you. Be careful, okay? Be careful with your next nitro. Get those fluids hung like you're supposed to. Which brings up another point. When somebody's having a cardiac event, why are you starting locks? You should be hanging lines. Because what if that patient's got right ventricular involvement, you gave them a nitro and you just tanked them out at 80. Now you've got to go back, repurge a line, get the line ready, and hang it. Hang the line to begin with on your cardiac events, okay? Those locks are costing you more time in the back of your rig, which means your patient more time. All right. These two things are seen off the 15 lead. So let me show you where 15 lead goes real quick. Come here, Johnny. Come on up here. On your paper, this is the very, very, very last sheet on your paper about a 15 lead. How are you, sir? Okay. I've got my patient, I did a 12 lead. Now what do I need to do? Well, you need 3 more electrodes. That's all you need is 3 electrodes. Okay? So, I've got V4, 5, and 6 right here. I need these 3 electrode wires off. I'm going to come over here in the V4 position on the right side. So, 5th intercostal space, mid-clavicular. I'm going to the right side, mid-clavicular, 5th intercostal space. There's my V4 wire. I snapped it off here. I put it on here. That becomes V4R. V4R, it's looking at the right ventricle. Okay? Now I snapped off 5 and 6. I go to my patient's posterior side. I want to find the end of his scapula. Okay, so the end of the scapula. Go about 2 fingers breadths below the scapula, and directly below it I want to put an electrode. Then I find his spinal column, and in between that electrode and his spinal column goes the other electrode, right there. V5 goes right here and becomes V8. V6 goes right here and becomes V9. So that's the pictures you guys have there on your handout. Then I just run the 12 lead like I ran my other 12 lead, only now when it prints out, I scratch out 12 and I write 15. On the far right-hand side of that 12 lead, I scratch out V4 and I write V4R. I scratch out V5 and I write V8. And I scratch out V6 and I write V9. That's your 15 lead. Okay? What you're looking for is this. The right ventricle, V4R, is elevated if you have right ventricular involvement. You got a STEMI, it looks like a STEMI in V4R. ST segment elevated. Okay? If you have posterior involvement on the 15 lead, you have V8 and V9 elevated. On the 12 lead, if you have posterior MI, on the 12 lead, V1 through V4 are your reciprocals, which means if you're looking at a 12 lead and you have depression in 2 or more of V1 through V4, that's a possible reciprocal on a posterior MI. That is one indication out of a couple to do a 15 lead, because there's a good chance when you do the 15 lead, 8 and 9 are going to be elevated. Okay? So that's your 15 lead. There's a lot of information on the very end of your handouts about 15 lead. Those are the lead groups. Does anybody have any questions at all on these lead groups? Okay? I'll tell you, it's all on your handout. Anterior. For those of you that are like those scientific brainiac people, anterior leads 3 and 4, the shaded area is what it's looking at on the left ventricle, if that's you. You want to know that's you. That's the anterior view. I gave you the pictures. This is the inferior view. The shaded areas are inferior. Shows you all of the anatomy in case you're interested. There's the lateral view. When you're looking at the lateral leads, that's the view of the heart you're seeing on the left ventricle. So again, if that's your gig and you want to know all that kind of stuff, it's on there for you. Septal, of course, down the septal pathway. All right, right, let's look at this one. Let's start at the beginning, okay? Let's start at the beginning with the 5. What's the rate? What's the rhythm? Do I have P waves? Are they rounded up right? A QRS for every P, a P for every QRS. What's my PRI interval and what's my QRS? So let's start there because this is a picture of a lead 2 script right here. So when you're looking at this, first of all, what's your rate? What's your rate? 42. Why is your rate 42?
2.5 seconds.
That's a 10-second strip. You count your R waves, what are you multiplying it by? 6. Not 10, by 6. That's a 10-second strip. So multiply it by 6. That rate's 42. Okay? All right, now let's look at access. Oh, what do you think it is, by the way? Here's your P waves. They're round, they're upright. PRs appear to be within normal limits. My QRS complex also appears to be less than 0.12. What do you have? Sinus what? Sinus bradycardia. Okay, sinus bradycardia. Let's look for access next. Lead 1 QRS is which way? Up. Lead 3 QRS is up. Do you have any problem with access? No, they're both up. No problem at all. And by the way, if 3 is not readable to you, you may choose to look at AVF. That is an acceptable alternative to 3 for access. Okay? All right, let's look at bundle branch. I'll tell you that the QRS measurement on this particular one is 0.08. Do you have a problem with the bundle branch? No. Moving on. Moving on. Now let's look at inferior leads. Where am I looking at? What's my inferior lead groups? Here's 2, here's 3, and here's AVF. I'm looking for ST elevation or ST depression. What do you note? ST elevation. You must have that finding in at least 2 of the 3s. Do you?
Yes.
Okay, you have it in all 3? Yeah. Okay. Now let's look at septal. What leads are you looking at for septal? V1 and V2. What do you note about septal? V2 has ST depression. Do you all see that? If you guys can't see in the back, you really need to move forward. There's a lot of open seats up here. So you have ST depression in V2, okay? But you don't have it in V1. You got it in V2. How about V3 and V4, which are the anterior views? ST depression in 3 and 4. Do you all see that?
Yep.
Okay, duly noted. Now let's look at lateral. Lead 1 over here, top left. AVL right there, square in the middle. V5 and V6. What do you have in those? ST segment depression in 1 and AVL. So think about what you have. You have ST elevation in the inferior leads of 2, 3, and AVF, and you have ST depression in 1 and AVL, which is known to be what? The reciprocal change for an inferior MI. Okay, you all see that on your sheets or whatever you're referring to? Okay, so you have an inferior MI with reciprocal changes. So that's significant event happening for your patient. Does anybody else see anything else we should pursue? 15 lead, why? Because you have depression in at least 2 of the V1 through V4s. That's the reciprocal change for a posterior MI. Okay? So if you had time, you'd get a 15 lead. Please know that American Heart Association no longer even says EMS should do 112 lead. American Heart Association's recommendation now is for what's called serial 12 leads. So serial 12 leads meaning you should be doing more than 1 in the field. Now for the majority of you guys, you have extremely short ETAs. That typically will not happen, okay, with your really short ETAs. But for some of you outliers, Bill, for you guys might get to 2 or 3 12 leads depending upon how far away you are. Fayette County in the back, you guys should be doing serial 12 leads. Okay? Depending upon where you're at, you would consider doing a second 12 lead. Okay? All right, so see, you guys just did that one. You did that all on your own. What's the difference between STEMI and non-STEMI? Treatment. STEMI, immediate cath lab. Non-STEMI, medications, cath lab later for diagnosis, hours or days later. That's the difference. STEMI markers. What constitutes ST elevation? ST elevation is anything that is greater than 1 millimeter in all the leads except septal. Septal requires 2 millimeter increase. Okay? So how much is 1 millimeter? One small box, that's right. One small box is 1 millimeter. Okay, must be present in 2 or more related or anatomically contiguous leads is how they define it. It's a big fat word for it. Has to be in 2 of the lead groups in that specific area. Okay? What does ST depression mean? Well, sometimes it means reciprocal. The other thing I wanted to make sure you have the attention to is it doesn't have to be a reciprocal change. It can also be due to medications the patient's on, such as DIDGE. That's a really guilty culprit of it. And it can also be ischemia or injury from an old infarct that has happened. So all reciprocal or all ST depression is not necessarily a reciprocal. This is ST elevation with reciprocal changes. For those of you that still are having a hard time figuring out what ST elevation truly is, this is showing you elevation in, if you look at the septal leads, V1 and V2 are elevated. Here's anterior elevation in 3 and 4, and then lateral, there's 1, AVL, V5. V6 does not have any elevation. Please remember, we're looking at elevation of ST segment. We are not looking at T waves. We're looking at elevation of ST segments. And then this blue highlights what a reciprocal change looks like. Depression, okay? So that's just another view of an elevation and a depression. Okay, moving on. Let's practice another one. Now, in these early practice sessions, I'm not feeding you the physical exam or the history information. In some of the ones to come, I'm going to give you all that information before you see the 12 lead, because it's going to be the deciding factor. Are they having a STEMI or are they having a STEMIC? Once you hear that. These right now are all STEMIs of some sort. Okay? So here's your lead 2 on the bottom. What's your rate? Is your rhythm regular? Do you have P waves, round, upright, present for every QRS? How's your PR interval and how's your QRS complex? What is your underlying rhythm? Always have to define it. What do you got? What's the rate? Approximately 60. Approximately 60. Okay, so do I have P waves? Yeah, you got P waves. Upright? Sure. PR interval, it actually appears to be a little long if you can see that far. It appears to be at about it's somewhere in the ballpark of 0.20 or 0.22. My eyes aren't that good right now, but let's just for the sake of things say it's 0.20. Is that okay? Mm-hmm. It's okay. And your QRS complex measures 0.10. How's that? It's also fine, right? So what do you have? Well, according to this, it's 60. Is that sinus per sinus rhythm? I don't know. Let me take my patient's pulse, and I'll tell you what I have. Okay? All right, next we're going to look at the axis. QRS complex in lead 1 is which way? Up. QRS complex in lead 3 is which way? Up. Do you have a problem with access? No. The QRS measurement was 0.10. Do you have to worry about a bundle branch? No. Wow. Going right through this. Let's look at our inferior leads first. Where am I going for those? Here's 2, here's 3, and here's AVF. What do you got? What do you think? I can't hear you. Possible, a little bit of depression in 3 and AVF, possible. Let's look at septal, V1 and V2. Remember, in septal we have to be greater than 2 millimeters. So V2 appears to be greater than 2, but V1 is very questionable. It's about a 1, about 1 box, so that doesn't cut it, does it? How about V3 and V4? Obvious elevation. Do you all see the elevation? Okay, significant. I mean, if you look up here, we're talking 1, 2, 3, 4, 5, 6, 7, about 7 millimeters of elevation. Okay, so that's obvious there. How about what comes next is your lateral leads? Where are you looking at for lateral leads? 1, ABL, V5 over there, and V6. What do you see?
Elevation of 1, ABL, and V5.
Pretty much elevation in all of the lateral leads, right? Okay, what do you have? Well, anybody want to call it? What do you have?
Lateral anterior.
Huh?
Lateral anterior.
That's exactly right. You have an anterior lateral STEMI, and do you have reciprocal changes for anterior lateral?
Yeah, inferior.
In the inferior leads, you do. Very good. So you have Anderson Hospital, we've got an anterior lateral MI, we've got a STEMI. Reciprocal changes in 1 and AVL. There you go. There's your declaration. Okay? Elevation in your anterior and your lateral leads, and you have the depression in the reciprocal, which was 2, 3, and AVF, 2 of those 3. Okay? Anterior lateral, what do we remember about the anterior portions? Deadly consequences, very fatal. For some of you, I wanted to give you a little bit more information because you are a little more progressed than the basic level. I wanted to remind you that T-wave inversion can be an early sign of ischemia, can also be a late sign if the event has happened. Also wanted to remind everybody, so it's in bold, that the ST segment can change or disappear as the area is reperfused with nitro. Occasionally you might see that. And pathological Q waves, for those of you that are in here that understand what I'm saying, please remember that it is the width of the Q wave as it progresses, not the depth. Okay? So it's the width. We already talked about that. This is a picture of, just so you have it in your handout, they enter with a catheter either from the left side or the right side. It's all cardiologist dependent, whatever their comfort level is. And then they thread the catheter, the balloons, etc., up and into the heart that way. It's just a picture for you. This is a good picture to give you an idea of how some people progress with their STEMIs before the infarct. Everything looks great. I don't have a Q wave. I've got a R and S on this patient. Not everybody has to have a Q wave, right? We all know that there's QRs, there's RSs, there are RS, R primes. There's all kinds of complexes out there. This is what this person's looked like. As they progressed, the ST segment elevated and the Q wave started to become pathological. Q wave continued to become pathological, but look what happened to the T wave once it was hours to day into it. It flipped. A flipped T wave happens sometimes as a result of the ischemia or the event. A week later, patient's already home. You guys pick that patient up. He's got a pathological Q wave, and he's got this inverted T wave. Don't freak. It might be a sign that, hey, he's had a recent cardiac event. Ask him. What's your history? Have you had anything happen recently? Because you're seeing this and you're like, man, that doesn't look normal to me. And then sometime, weeks, months later, look what happens to the T wave. Goes back to normal. Goes back to normal, but look at the Q wave. It doesn't change. It remains pathological in its state. Okay? So that's a way that they do progress from the first stage through necrosis and through resolution. What do you do when you've got one? You got to let somebody know, right? That's what this whole process is about, declaring it. We've been declaring level 1 traumas for now 22 years. Anderson EMS has been saying we got a level 1 trauma we're coming in with. Please remember, the whole reason that we declare a level 1 trauma is not because we want to make sure you're smart enough to figure it out. It's because we want to make sure the patient gets the best chance of care that they can. And trauma is time dependent because they need definitive care, which is surgery. All time dependent. Cardiac muscle is time dependent. Patient outcomes are time dependent. So we should be declaring these STEMIs. Okay? Anderson Hospital, bringing in patient complaining of XYZ complaints. This is their history. These are their meds. These are their vital signs. We did a 12 lead. And we've got elevation in 2, 3 in AVF with reciprocal changes in 1 in AVL. We're bringing you a STEMI. That activates everything right then and there. When they hear the word STEMI, it's full activation. If it is after hours, they're called in and they have a very short time frame they have to be here within. Okay, it's a policy, it's a protocol, they have to adhere to it. So everybody's called in on your word in the field. The longer you wait in the field to call it, the longer it takes to activate the CAP team and get them here. Very important that you guys are doing this. If you can transmit, by all means transmit. The problem is, even if you can transmit, not all transmissions go through. Even the best monitors out there in the world have had plenty of hiccups over the last 2 years. So transmissions don't always work. The button was hit, but it doesn't acquire. All kinds of things can go wrong. That's why it's just tremendously important that you guys are capable of making this declaration from the field. Okay? If you can transmit, you go for it. Remember, the machine printout is only 50% accurate. That's why you have to take the 12 lead, the physical exam, and the history all together in order to create what you believe is your patient care plan or what your ending outcome is. Treatment, oxygen monitor IV. You know treatment's been changed here. Please remember to give your aspirin, though. Give your aspirin if it's indicated. Watch your contraindications. Aspirin, when it's added to the additional medications they give them in either the ER or the cath lab, reduces mortality up to 20 to 25%. It's one of those synergistic effects. If we give this medication without this medication, then this is 20% effective and this is 20%. If we give these two medications together, they become 75% effective. It's that type of effect. So aspirin is one of those drugs that facilitates the other meds. You want to make sure you're getting that aspirin on board so it's in their system before they ever reach the hospital. Nitro and morphine still remains in your guidelines, but just ask yourself the question, are they relying upon preload? Do I have my IV line established? Have I checked their blood pressure? Have I reassessed their blood pressure? Okay, make sure you're doing your job on following those reassessment guidelines. Pre-hospital 12 lead serial we already talked about, and when you would do them versus when you don't have the time to do them. As far as activation of the STEMI, this is probably the best time in the world to cross this bridge right now. To date, we've not had a false activation of a STEMI. That's EMS. That's phenomenal. We've had one activation that wasn't a STEMI, but she appeared, she had everything on the 12 lead. The cardiologist looked at the 12 lead and went, oh yeah, it's a STEMI. Rushed her in there. She was a 5-vessel occlusion, but not what he called in the end a STEMI. That was still a success for us. It was a success for the patient, and the cardiologist was still happy about it. Okay? Everything else has been true blue STEMIs from EMS. So you guys have done a phenomenal job with what we've done so far. Okay? And that's the pathway we want to take. If we get a false activation, it's not going to be the end of the world, people. ER doctors falsely activate cath labs. Other physicians falsely activate. Cardiologists falsely go to a cath lab. It is not hundreds, but it's thousands of dollars to take a patient there, but chances are if you didn't call the STEMI and get them there tonight, they're probably going in the morning when they see them on their rounds. So the cardiologists are giving you guys a whole lot of credit. I will tell you that at one of the last meetings, and there's three paramedics attend these meetings with me and Eric and Jean and soon to be Steve, etc. So 3 of your fellow peers are at these meetings, so they can tell you the same stories. At the meeting right before our cath lab went 24 hours a day, 7 days a week, the cardiologist said, they were talking about activation in the middle of the night, etc. And I said, so they wanted to know when you guys were getting validated. And I said, so let me get this right. In the middle of the night, you're going to take their word for activating you and waking you up in the middle of the night, even if they can't transmit the 12 lead. And he said, absolutely. I've seen their training. I've seen what they've done so far, and we are to be activated. And I said, so what happens if it's false? Are you going to be mad because we woke you up at 3 o'clock in the morning? And he said, absolutely not. He said, we will not be mad. It's our job. So we have the word from the cardiologist that you guys do your job, they'll do theirs. Okay, and they've held to it, man. I'm telling you, they are really, really, really doing well with EMS. Dr. Cruz, I think, was a little offended because the last cardiologist on the last STEMI literally walked right past him to the paramedic. Didn't want to talk to Cruz, went right to the paramedic. So it was kind of comical, to be quite honest. So remember, do your job. If for some reason we look at that 12 lead later and we go, can't figure out what they were looking at here, can't really tell what they were looking at, what do you think we're going to do? What's your past thing for when do we ever call you? Tell us what you saw. Terry, tell me why you called it a STEMI. And if we need to, what do? Do we yank your license? Have we ever? No. Have we ever suspended anybody on calling a level 1 trauma and it wasn't a level 1 trauma? Never. We're going to remediate. We're going to go, hey, Wiz, what'd you see on the paper here? And Wiz will go, well, I had elevation in 2 and V1 and V5. And I'll go, you're right, you did. The problem is they're not all in the same lead group. And we'll just educate them through the process again. Okay? That's what we're all about. That's what we will continue to do. Okay? If it's blatantly wrong, we'll educate you. If we can see what you saw, then it's not a big deal. Okay? Remember, you're not expected to be perfect. There's going to be impersonators, but we're very confident that if you look at everything as a whole, you're going to figure them out. So we're going to start practicing with histories and assessments. Okay, this first one I want you guys to do without a history or assessment, and I want you to do it yourself to see how well you're doing with the process. So I want you to write it down, keep it in your head, do whatever you need to do, but I want you to go through this in about 30 seconds, and I want you to be able to say what this is. Let's see how your process is working. For the sake, sorry, I didn't give you a QRS measurement. The QRS measurement is 0.06. All right, let's look at it. Access. Lead 1 QRS is which way?
Up.
It's up. How about lead 3? Up. Do you have a problem with access? No. How about your QRS? Is it too wide?
No.
So do you have a problem with bundle branch?
No.
No. Let's look at our lead groups. Inferior comes first. What leads am I looking at? Very good. Very good. 2, 3, and ABF. What did you note?
Elevation.
ST elevation noted in the inferior lead groups, and I have it in 2 or more of the leads, so that is absolutely important. How about septal? Up there, V1 and V2. Looks depressed, right? Let's go to anterior. V3, V4, top right. Some depression in 3, but 4 is normal, right? And now lateral. 1, AVL, V5, and V6. Depression where?
1 AVL.
1 in AVL. So this is depression right here. Y'all see that? This is your depression. ST segment depression here, ST segment depression. So you have an inferior MI. Where's your reciprocal changes? 1 in AVL. Do you have them?
Yes.
What kind of MI do you have?
Inferior.
Inferior MI with reciprocal changes. We're bringing you a STEMI. Okay? You also have depression in V1 through V3, which means if you had time, you could also do what?
15.
You could do a 15 lead if you had time. Okay? All right. The next one I want to give you a history on before I show you the 12 lead. I had a little bit of, this is a real life one that EMS brought in about a week and a half, 2 weeks ago. I had a little bit of the history until last class. Last class, both the medics were present, so I was able to get the full story on it. You have a question? Oh, so here's the history. The man is working outside doing a paid job for a lady. She looks outside. She sees him appearing to have some discomfort. Chest, trouble breathing, that sort of thing. She calls 911. The ambulance gets there. The man is adamant he is refusing. He's adamant he's refusing treatment. He has extensive cardiac history. He's refusing treatment. They convince him to let them check his blood pressure, his vital signs, and do a 12 lead. They check his vital signs, all normal. They do a 12 lead, perfectly normal. The man is excessively diaphoretic, but then again, it's like 110 outside with the heat index. He's working outside. Excessively diaphoretic, obvious pain, obvious discomfort written all over his face, and he's adamant he's refusing. So they do their best to talk him out of refusing. Everything's normal findings though. He promises he's going to take himself to the doctor, to the hospital, etc. They fill out a refusal form because he's literally adamant about this. Call medical control. Do everything they're supposed to do. And at somewhere in the point in time, he stood up. And when he stood up, he got real kind of dizzy and off kilter a little bit. Unsteady gait, as it was documented. Okay? So they tell him that look, we don't know what's going on with you. You could be having a heat stroke related event. You could be having a cardiac event. But if you don't let us take you in, there's a good chance something's going to happen. So he says, the only way actually at this point they said, let us do another 12 lead, and he agreed. So they did another 12 lead. I'll show you that in a minute. After doing the next 12 lead, the medic says to him, if you don't go to the hospital, you're going to die. Okay? Now remember, 5 minutes earlier, the first 12 lead was normal. This is the 12 lead. Somewhere. Here it is. So, lead 2. If they had just put him on a monitor, here's lead 2. What do you see? Hey, it looks like a pretty little sinus rhythm, doesn't it? It's got all the components you want to see. Hey, dude, you're right. There's nothing wrong with you. Sign this refusal. But they didn't do that. They did a second 12 lead. Second 12 lead. QRS up, QRS up. Do they have a problem with the access? No. QRS measurement. It says 104, which is 0.10. Do they have a bundle branch? No. Moving on. Let's go to inferior. 2, 3, and AVF. How's it look to you, boys? Girls? No offense. How's it look? Looks pretty damn good. Looks pretty good. This is all normal. This is all normal. Got slight depression right there, but there's no depression anywhere else, so it's not significant. Let's go to septal. What do you see in septal? Here's the isoelectric line, and here's your ST segment. Here's the isoelectric line, here's the ST segment. Same thing here. What do you see? Elevation of the ST segment. Don't look at the T waves, look at the ST segment. Elevation. How about anterior? That's normal. That comes across barely, but it's pretty normal. How about up here? Anterior spine, isn't it? How about lateral? 1, AVL, V5, and V6. Any of you notice the inverted T waves going on? There's some inverted T waves going on too, but you don't have to note that, but I'm just throwing it out there in case you did. Lateral looks normal as well. So what do you have on this? You have a septal infarct going on, a septal STEMI. Where's your reciprocal for septal? There isn't one. Very good. Very good. So Anderson Hospital, we're bringing you a STEMI. Septal leads, V1 and V2 elevated. Okay? So they told the guy, if you don't go to the hospital, there's a really good chance you're going to die. He agreed to go to the hospital only if he could pick up his tools and he could walk himself to the ambulance. Again, they told him the dangers in him exerting himself and documented what the patient would not do and would do because they're covering their butts big time on this patient. So, cardiologist waiting at the ER doors for this patient. This is a patient that went straight to the cath lab off of EMS's stretcher, went off of EMS's 12 lead, and he was 100% occluded. Okay? Reperfused very, very quickly, and the cardiologist said he would have died. This man would have died due to his 100% occlusion. Instead, he was dismissed about 36 hours later. He was discharged from the hospital. Unbelievable the difference. Why? Because they took the time to do a second 12 lead and see what was going on with the patient. So we're extremely proud of this event that happened just recently. 41 years old. That's him. Okay? This is his reperfusion. You can see the arrows pointing to where the occlusion was, and then that's him reperfused. So you can see what a difference it made. Turn down. Okay, let's do this one. I don't want you to look at the 12 lead yet and decipher it. Here's the history. You're called out to responding to a 68-year-old female patient with a cough and chest pain. So you guys get there, we're blowing past the whole scene, size up, safety, BSI, blah, blah. For the sake of time, let's move on. What do you want to know?
Presentation.
Patient sitting up in a chair. Sitting up in a chair telling you that, hurry up, I have chest pain and I hurt. Take me to the hospital, boys, girls. What do you want to know? What are you asking her? You guys do your job. Tell me what you want to know.
History.
What do you want to know about the history?
Any cardiac events?
When did it start? Well, it got worse today. Started about 10 days ago.
What were you doing that got worse?
I was sitting in my chair watching Price is Right.
Anything make it better or worse?
Well, it feels better when I sit up. It hurts really bad when I lay down, but it feels better when I sit up. Past medical history? She tells you that besides going to the doctor about 10 days ago and getting these pills that are so big they look like horse pills. Look at these, they make me swallow them. So I felt better after about 3 or 4 days I stopped taking them. What? What are they? They were an antibiotic. The doctor told her that he didn't think they would help because she had a virus, but to shut her up, he gave her the antibiotic. Okay? Other than that, she has no past medical history. What else you want to know about her physical exam findings?
Scale of 1 to 10.
She's running a slight fever, low-grade temp. Does the pain go anywhere? No, it hurts worse when I cough or I lay down, but as long as I sit up or I don't cough, then it's better. It's not productive. No, it's a dry cough. It's not productive cough. All right, so your nice little partner that you got, put her on some supplemental oxygen, hooked up to 12 lead, this is what you have. So, access, lead 1 and lead 3. Lead 1 is up and 3 is 50-50. Do you have a problem with your access? No, it's normal, right? I'll tell you that the width of the QRS is 0.08. Do you have a problem?
No.
No. Let's look at our inferior leads. So, what leads are you looking at?
2, 3, and
2,
AVF.
3, and AVF. Here's 2, here's 3, and here's AVF. Duly noted what? Elevation in all 3. Next we go where? Septal, V1 and V2. What do you notice? Hey, we got some elevation going on. It's 2 millimeters, so it's elevation. How about V3 and V4? Elevation. How about lateral? 1, AVL, V5 and V6. There's 1, AVL looks good. Here's 5 and 6. So her entire heart is infarcting. What do you think? She is. She's pericarditis. She's pericarditis with her history and the 12 lead findings. She is pericarditis. Her entire heart is not infarcting. You do not have any reciprocal changes, and you have a history that tells you she had a viral infection. She has a fever. She has a dry cough, and she feels better when she sits up. Lung sounds are clear and equal. She's pericarditis.
When you go for that ST elevation, and you said the T, the height of the T doesn't matter any, what are you looking at? Where are you measuring at?
You have to measure the ST segment. The ST segment is what comes back to isoelectric line. So you're looking at, this is a T wave. This is your ST segment. Okay? This is ST segment here. So here's my isoelectric. This should pick right up off of here. But instead it's way up here. That's my ST segment.
Okay.
So you can see
Yeah,
it is 2 boxes off of where it should be.
Okay.
Okay? Here, this is your ST segment. This area right here. Okay? ST segment. You see that, Mitchell?
Yeah.
Okay. Okay, this one. You respond to a local YMCA. You go to the local YMCA and you get called for a man that fell off his treadmill. He fell off his treadmill, but don't worry, somebody caught his head. He didn't hit his head. You don't need to worry about trauma packaging. It's all good. Okay? So you get there. What do you want to know? Questions? How fast was the machine going? About as fast as he's always gone. No loss of consciousness.
Did he trip or feel dizzy or?
He felt dizzy. He got exceptionally dizzy while he was on the treadmill, and the next thing he knew, he was going off the back of it.
Never happened before. That's medical history.
How often does he work out? He works out 4 to 5 times a week. Past medical history, 0. Short of breath. A little short of breath. Nauseous? No, not nauseous. A little short of breath. Has it ever happened before? Nothing's ever happened before except for about the last week. Every time I get on the damn treadmill and I hit about 2 miles, I get really dizzy. I've had to stop. Instead of going my normal 5, I've had to stop at about 2.5 miles. Today at about 1.5 miles, I was done. I don't know what's going on. No, he's got a little discomfort, a little shortness of breath, a little, he calls it discomfort going on in his chest. Hit us up. Okay, here's his 12 lead. Access, lead 1 is up and lead 3 is up. Any problem? No. QRS measurement, 0.16. Problem?
Yes.
What lead you going to? Go to V1. Find your J point. You guys already know. What kind of bundle branch is it? It's a left bundle branch, right? So what do you think's going on with this guy?
The rate induced.
Exercise induced, rate dependent, possibly simply new onset left bundle branch, right? Does he need to go into the ER for evaluation? Absolutely, because the left bundle branch is a block of the bundle branch system on the left side, right? So he needs to go in, he needs to be evaluated, possibly even capped to see if he has any coronary occlusions, because what we know is with the left bundle branch, it kind of distorts the rest of our ST segments. So it's kind of hard to see what we have going on with that patient. Okay, it's a left bundle branch. Let's see. When was this one? Oh, the real history on this patient. This was a woman in her 60s. She called EMS because she didn't feel good. She was weak and she was short of breath. She had a pretty extensive past medical history, inclusive of things like diabetes. She had a lot of female-related issues, but she had never had a coronary event. Okay, a lot of other things, hypertension, that sort of thing, but no coronary event in the past. So this is her 12 lead and her monitor. So down here we notice that she is a sinus Brady, right? And very slow sinus Brady, as a matter of fact. So is she symptomatic sinus Brady? Well, it's possible, but let's see what our 12 lead shows. 12 lead, QRS in lead 1 is up and QRS in lead 3 is up. So up and up. Is that normal? Yes. QRS measurement, according to the strip, is 9.0, which means 0.9. Do you have a problem with the QRS? No problem, right? Let's move on. Next we do our inferior leads. 2, 3, and AVF. What do you note? Elevation in all of them. You all see that? ST segment elevation. Okay, now septal. V1 and V2 over there. Depression. How about your anterior leads, which is V3 and V4? They look fine. They look fine. How about lateral? Here's 1, AVL, 5 and 6. What is depression in 1 and AVL?
Reciprocal.
Reciprocal for what? Inferior. What was she having? She's had an inferior MI. So Anderson, we're bringing you a STEMI. It's an inferior MI with reciprocal changes. This one was called in the field by a service that cannot transmit. Cardiologist was waiting. This was the one, if you were at Run Review, I told the story of almost barging into the room to remove the EMT student, and it turned out to be the cardiologist dressed in EMS pants. This was the call. She did very well. It was very quick. They didn't do an ER 12 lead, nothing. They put her on the ER stretcher and then literally unlocked it and wheeled her down. So it went really fast. This is her. That's her occlusion up at the top, and this is her reperfused. Okay, so some pretty cool pictures. The siren in the middle is the radio report. It's just I can't get it on this computer. So I actually listen to your radio reports. Okay, this one. She's a 72-year-old female patient with an extensive past medical history. If you ask her if she has it, chances are she's going to say yes. She's complaining of severe shortness of breath and chest pain. Okay, any questions you want to know right off the bat before I show you the stuff? Initial assessment, her respirations are running at about 32, her airways open and clear. You can hear her breathing. She has audible lung sounds as you enter the room. Blood pressure is 160/92. Okay, anything else? You might have a few questions here in a minute. Don't shout this out. Do this one yourselves. Let's see how many of you figure out what she's got going on. Okay, probably through it. Lead 1, QRS is up. Lead 3 is down. So I have to look at lead 2, right? I have one up and one down. They're looking away from each other. I have to look at lead 2, and lead 2 is 50-50. Is it normal or is it a block? It's normal. Up, up, down. Okay, or up 50% and down is normal. So there's no block there. I'll tell you that the QRS measurement is 0.14. She's a left bundle branch. What else you note on there? What other questions might you have at this point? Because there's one question that will tell you exactly what's going on with her. What?
What does the potassium?
You don't know that. You're in the field.
I mean, does she take potassium?
Dialysis patient?
She's on all kinds of medications, and yes, she is a dialysis patient.
Ding, 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 ding.
What do you want to know? Did she what?
Has she gone to dialysis?
She was supposed to go to dialysis 2 days ago, but her ride called and canceled. Yeah, she's a left bundle branch and she's hyperkalemic, right? So if you just look at that and you don't take the time to ask the right questions, you might have misinterpreted that. But with the right questions, the right history, you guys will get it. That one, I'm not going to take the time to do this one because it's what you're used to seeing. This is the inferior again. Inferior MI, okay, with reciprocal changes. So that's a STEMI. This guy right here, he's got chest pain. He lost his job. He lost his wife. She took the dog. And he can't sing, so he cannot tell you the country song. But, so, what do you want to know about it? Let's pretend that you're not looking at that yet. What do you want to know? Past medical history. How you feel? How's your ABCs? Airway open and clear. Breathing. He's breathing 20 times a minute, slightly labored. 20 times a minute, slightly labored. Circulation. Skin is pale, cool, and clammy, excessively diaphoretic. Complaints. What hurts you, buddy? Signs and symptoms out of your sample, right? Signs and symptoms. He tells you that he has sharp stabbing chest pain. Goes into his chest and out through his back. Allergies, none. Medications. He used to take some high blood pressure medication, but when he lost his job, he lost his insurance, and he had to stop taking his hypertensive medication because he can't afford it. How long ago was that, sir? These are all questions you guys be asking, right?
Of course, yes.
6 months ago. If you don't ask the questions, you don't get the answers. 6 months ago, he had to stop taking it. Okay? So right now, knowing his history, what are you, and his presentation, what are you kind of thinking? Well, it's possible it's anxiety, but my gosh, he's got a history that would lead you to believe he's a risk factor for what?
AAA.
For strokes or for aneurysms or for cardiac events, right? He's got all of the associated risk factors that AHA publishes. So you do your 12 lead. Axis is fine, up, up, down. Axis is fine. QRS measurement, 0.06. It's fine. Inferior leads, 2, 3, and AVF.
Good.
Anything significant? No, nothing significant. V1 and V2. Questionable elevation in V1 because of the height requirement of 2 millimeters, but V2 looks okay. How about 3 and 4? Anterior Elevated, how about lateral? 1 AVL, 5 and 6. Nothing? What's my reciprocal for anterior?
2, 3, 8.
Do you have it? No, no reciprocal. So again, stabbing chest pain in through the center of his chest, out in his back. Hypertensive, history, medical history, no meds for the last 6 months. Extremely pale, cool, clammy, diaphoretic. Blood pressure starting to drop on you. What do you think? Huh? You could do a 15. Sure, you could do a 15. 15 leads normal. Yeah, he's got kind of a knife sticking through him. Kind of like a knife. Kind of hurts, kind of hot. Stabby. Physical exam, what do you want to know? I'll tell you, peripheral pulses are absent. Absent peripheral pulses. Yeah, he's got an aneurysm working. This guy's got an aneurysm working. He is not a STEMI. Okay? He's got an aneurysm. You do not have reciprocal changes on this guy, and you got the history. Presentation, remember your presentation. Okay, maybe sometimes you should review presentations on events. This woman, 40-some-year-old woman, questionable exercising. That's me. We'll say that's me. Okay? That's why you don't get to know how old. 40-something-year-old woman exercising and dieting because of a vacation. So you know the big have to get into the bathing suit, right? So exercising, dieting, all of a sudden has some chest discomfort, shortness of breath, mostly shortness of breath, calls the ambulance. Airway opening clear, breathing about 28 times a minute with some work to her breathing. She's working. Okay. Circulation, skin, she's kind of sweaty. Color appears to be okay though. She's kind of sweaty. Her pulse is running at about 80. Okay. You guys get there. Past medical history, 0. What else you want to know? Lung sounds are clear and equal. What else? What do you want to know?
Has she been eating and has she been taking diet pills?
Oh, good questions, Mary. Those are great questions. I haven't been eating very much, and don't tell anybody, but I might be taking some diet pills. But don't tell anybody. Why is that important, Mary?
Because that explains what's going on. She hasn't had any food, and now she's probably taking some kind of upward thing.
Possibly, yeah, possibly. Plus, those diet pills are stimulants, chances are. So she might have been tacking out for a while, which created some hypoxia, which created some PVCs, right, that you're seeing up there. You all see the PVCs? Exercise-induced, possibly. Okay. I'll tell you, you do a D-stick on her. D-stick's normal. So obviously her blood sugar's okay. All right. You run the 12 lead. Your perfect little partner goes, hey, see if you can get a refusal. 12 lead's normal. She's got some PVCs, but everything looks okay. See if she'll refuse, because man, dinner's waiting. So you do the 12 lead. Access, lead 1 and lead 3. 1 is up, 3 is down. So we have to look at lead 2, and it is which way? Up. Do you have a problem? No, not at all. QRS measurement is 0.04. Do you have a problem there? Nope. How about inferior leads? What do you see? They look good, don't they? You notice you've got some multifocal PVCs going on. Okay. How about septal leads, V1 and V2? Depression in 1 and 2, don't you? V1 and V2 both are depressed. How about anterior leads, V3 and V4? Depressed. Okay, how about lateral? Go to 1, look at AVL, then look at V5 and V6. Look pretty normal to you? So do you concur? Let's get a refusal, and she'll be fine if she stops taking her diet pills and she stops exercising. Do a 15 lead. Why? Because she has the reciprocal for posterior MI up there. So you do a 15 lead. Sometimes you have it, sometimes it'll be normal. This time she had a posterior MI. She had elevation in V8 and V9. The woman had a posterior MI and went to the cath lab. Okay? Not always will you have it, but you've got the indications there for a 15 lead. So you do it. Let's see. Let's do this one. What is this one? Just look up here and tell me if you know what it is. It is. What do you got? Who knows? It is pace rhythm. It's a working pacer. That's a pace rhythm. You all see the pacer spikes? That's a pace rhythm. Don't forget those things are out there, right? We get hung up on all of the other stuff. Sometimes we forget what we were supposed to remember. You've already done that one, so we're not going to do it again. This one, it's kind of hard to see, but I want to show you this. This one is a septal anterior. For the most part, it was septal anterior. It had depression in your reciprocals. Your reciprocals are depressed. But look at the size of this infarct. Look at this. V3, V4, and then the septal leads. Okay? So what is my reciprocal for septal? There isn't one. What is my reciprocal for anterior? 2, 3, and AVF. And you've got it, don't you? So that was a anterior septal or a septal anterior. More times than not, you will see those two together. Septal and anterior like to cling on to each other. This was one, I don't have the 12 lead on this, but the story with this one of my students in this room called this one a week and a half ago in the field. So that's pretty good considering they've only known the stuff for a couple of weeks, 2, 3 weeks. So this was a patient that they brought in from the field, occluded. You can see the big occlusion from the left to the right. You can see where it's at. It was a right coronary artery. It was an inferior MI. When I looked at the 12 lead, the lesson learned on this was I looked at the 12 lead, they called it, and they called it without a reciprocal change. But when we looked at the 12 lead, the reason there wasn't a high quality reciprocal change was because there was too much artifact on the 12 lead. Right, AJ? Right. So next time, what did I tell you? If you want to see your reciprocal real well on this one, make sure that you reduce the artifact. Make sure those electrodes are down nice and tight, or run a second 12 lead, stop the shivering, stop the shaking, stop her from talking, or have her hold her breath to reduce that artifact. So got lucky on this one, called it based upon the elevation, even though there wasn't a visible reciprocal, and it was a big fat stemming. Okay? This information is on there for you. I'm not going to cover it. Because we've already talked about it a little bit. This is the 15 lead stuff, the criteria and the reasons why we do it. We talked about we do it for a normal 12 lead, and we also do it for ST depression in V1 through V4. The other thing to remember is inferior infarcts have right ventricular attachment in about 50% of the cases, which means reduced cardiac output. That's how to do it. That's what I showed you on John when he came up front. That's the description step by step on how to do it. That's how to document it. It's all on there for you, how to document it. The right ventricular infarct, more information simply tells you decreased cardiac output if it's involved. You don't have to do the 15 lead to know if you have right ventricular involvement. JGD, hypotension before or following the nitro, clear lung sounds. If you do the 15 lead, you will have elevation in V4R, and that does not have a reciprocal. Remember, those people need fluids when you're given nitro. And there's the posterior. Posterior can be separate from an MI, or it can attach to an MI. Either all by itself or attachment. Either one. How do you know you have it? ST elevation in V8 and V9 with reciprocal depression in V1 through V4 on the normal 12 lead. And that's the end of the lecture part. Do you have any questions? Anybody?
Jerry, I do.
Yep.
You were talking about the services that are farther out, running more than one 12 lead. If you're running down, if you're in the rig going down the road, aren't you going to get false readings with artifact and things like that?
Yeah, possibly you are. So just like AHA says, every time you shock a person, you pull your rig off to the side of the road. Same concept, right? Is it going to be done? Chances are no, but that's the theory behind it. Yeah, you're right. You're going to have artifact with road movement. You're absolutely right.